This is Becks Fisher, and nothing could give me more pleasure to introduce Becks. It's, as you can imagine, anybody who's involved in educating young doctors, educating young doctors, involved in the process of training. It's a moment of great pride when the former trainees way surpass them and reach dizzying heights in the health service. And I think no better example than that of Becks, who was my trainee in Cowley some years ago, and is indeed working in general practice in Blackbird Leys in Oxford. But that doesn't do her by any means justice, because she actually has become a senior policy fellow at the Health Foundation, and she leads on primary care policy. She's particularly interested in equitable provision of primary care services, and I'll tell us a bit more about that in a moment. And she's been looking at models of care and payments for general practice. She was previously working as the National Medical Director, Sir Bruce Keogh's Clinical Fellow. And she's also been involved in co-founding an organization called Next Generation GP. At the moment, as you might see from her picture, she's in America. And she is on secondment as a Harkness Fellow in Healthcare Policy and Practice in San Francisco. I understand that she's not been idle there. She's actually involved in ultra sports and runs Marathons Plus, and also I think has been occupied in warding off bears. Without further ado, and no doubt she'll tell us something about her contacts with bears, along with all the other things that she's going to discuss, I will hand over to her on the topic of level or not, health inequalities, the inverse care law, and general practice in 2023. Becks.
Peter, thank you. That's a very kind introduction of the sort that my mother probably wouldn't recognise. I'm hoping that you can now see my slides. Does that someone give me a wave? Fantastic. I am indeed hailing currently from San Francisco, which sometimes you can see the bridge and it looks like this, but often you can't because it's foggy. And recently we've had a bunch of storms that have knocked out power lines left, right and centre. So my hope is that we'll get through the half an hour that I plan to speak to you for unscathed. But if someone could please shout if the line goes wobbly, I'd be very grateful. That was a very kind introduction from Peter. And you're in some respects quite a daunting audience to speak with. I speak with bigger audiences regularly, but I rarely speak with audiences of people whom I know very well personally, some of whom have known me since I was a rather feisty and argumentative 13-year-old on a football field at Cherwell School. So it's a pleasure to be with you this evening, and thank you so much for inviting me. I'm going to aim to convince you of three things in the next 30 minutes. That the provision of general practice is fundamentally inequitable, that we won't successfully tackle health inequalities unless we level it up, and that levelling up is possible, but there just currently isn't political will to do that. I realise that some of you may have heard me speak about this subject before. For that, some apologies, but not complete apologies, because I think, to be honest, I'll be speaking about this until we manage to make significant progress. What we're going to do in the next 30 minutes is talk through these chunks. We're going to talk very briefly about health inequalities. I'm not going to spend long on that because I think you are likely very well versed in them. We're going to zoom out to talk about general practice from 30,000 feet. The reason I want to do that is because I think understanding the wider context helps us understand some of the political decisions that affect the situation we find ourselves in. We're going to talk about Julian Tudor Hart and the inverse care law. I'll show you some data that we've created in the last few years at the foundation that show how inequitable the provision of general practice in England currently is. We'll then talk about why that is, and we'll talk about what we can do about it. But first, why should you care? Well, I think probably everybody on this call does already care, but just to remind you, these statistics are pretty grim. So since 2010, life expectancy in England has stalled. It had been rising steadily from about 1900 onwards, but it's stalled and it's starting to go backwards. And the reason for that is primarily that inequalities in life expectancy have increased. For men, there's almost a 10-year gap in life expectancy between folk who live in the richest and poorest areas. For women, it's a little bit less, more like 7.5 years. But the gap in healthy life expectancy is even bigger. it's an almost 20-year gap in healthy life expectancy for women, 18.5 years for men. Lots of you will have seen this before. I quite like it. I'm not going to spend it long on it now, but this is a schematic of the central part of the London Underground. And I just want you to focus on the central line, the red line through the middle. What you're seeing in the circles is the average life expectancy in the neighbourhood immediately surrounding each stop. And if you just look right in the middle, you'll see Tottenham Court Road, live at Tottenham Court Road, and you can expect, Oxford Circus, you can expect to live a whopping 96 years. As you move out to the right of your screen through the East End of London, where many of my own family and my wife's family are from, by the time you reach Bow Road, 77. So it's about 5.3 miles away and a gap in life expectancy of almost 20 years. Closer to our patch, this is Parktown, which many of you will recognise in the north of the city. And this is the salubrious towers of Blackbird Leys, just over the ring road in the south of the city. It's probably about 20 minutes if you put your foot down on your bike, maybe a little bit more going the other way up the hill. But the gap in life expectancy is about 7.5 years and widening. So why should you care? Well, you may not, but I suspect that many of you, like me, think that this is unfair and unjust, and that those of us who work in healthcare can do something about it. And we also know how we can do something about it. And I want to be clear here that, of course, lots of that gap in life expectancy isn't amenable to healthcare. You'll see numbers vary. Sometimes people say 10% of the gap in life expectancy is amenable to healthcare. Some people would argue it's more like 20%. But either way, a large proportion of that gap is the social determinants of health, the conditions in which we live, we are born, we grow, we work, we play. There's clearly an increasing overlap in the role of healthcare in intervening in the social determinants of health. But there's also really important interventions that we can make within healthcare systems that improve life expectancy. There's loads of evidence around things like secondary prevention of cardiovascular disease, earlier cancer detection, and so on and so forth. So if you care about this, you will also understand that those of us who work in healthcare have levers that we can use to affect life expectancy. But I would argue that we are also affected by the systemic structures in which we work within, and that's what I want to focus on today. Before I move on, just a quick note on language, because I'm going to use the words inequity a lot, and I just want to be very clear about the difference between equality and equity, which I think many of you are familiar with. But equality meaning that each individual or group of people get the same resources and opportunities, whereas equity realizing that each person has different circumstances and allocating the exact resource and opportunities needed to reach an equal outcome. So I will be talking a lot about equity and inequity because I think that is what we should be striving for. Just for a second, I want to give you a 30,000 foot view of general practice. I think I know some folk on this call are GPs, and so this will probably be very painfully familiar to you. And I think anybody who has been reading newspapers in the last 6 months is well aware of this as well. But just to provide that broader perspective, we all know general practice is not in a good place at the moment, and there is a fundamental mismatch between demand and supply. Just to put some numbers on it. This graph just shows you the trend in appointments in general practice in England. I should be clear, actually, that all of the data that I'm going to use in the rest of my talk is based off English data. We use National NHS Digital set, so it doesn't reflect the situation in the devolved nations. But this graph shows you the trend in appointments in England since January 2018. It's wibbly because of the COVID lockdowns. And the scale, I'm afraid, is fairly small. Actually, it would look much bigger if we had an x-axis that went from 15 million appointments to a month to 30 million. So you may have to slightly take my word for it, but the number of appointments that general practice is doing each month is increasing significantly, and it's increasing fast. So in January this year, general practice in England did almost 30 million appointments. That's excluding COVID booster IMS. And that compares to and that's about 4 million more than the same time last year. So that's a 15% increase in a year. Now, you might say, well, that's fine. And you would be right if the number of GPs, the number of staff in general practice was increasing in proportion to the volume of appointments. But we all know that it's not. And so this graph, which I just nicked from a recent House of Commons paper, shows the number of permanent qualified GPs. And I just want to take a second to explain the difference in language here, because you will probably be hearing government saying there are more GPs and pretty much everyone else saying there are fewer. And it's just to do with who you count as a GP. So government will count GP trainees as GPs for the purposes of their language. And they are right in saying that since 2015, when government made a manifesto commitment to 5,000 additional GPs, the number of GPs in training grades has increased. And it's increased fairly significantly. There are now almost 4,000 GP trainees a year in England, which is good news. Government, as you all know, increased its manifesto. So having completely failed to achieve it by 2019, doubled down and said we're going to have 6,000 more GPs by the end of the next parliament, by 2024. That's a welcome commitment. Of course, we all know we need more GPs, but the problem is that the participation rates are decreasing. So the FTE equivalent of GPs is dropping. And of course, folk are leaving the profession as well. So the green line at the top shows the number of permanent qualified GPs, which is decreasing. And when you look at the number of full-time equivalent permanent qualified GPs, which I personally would prefer to use as a metric because I think it's most reflective of who is actually undertaking labour in general practice, we have the equivalent of just over almost 2,100 fewer fully qualified FTE GPs compared to the September 2015 baseline. So we are caught in this vicious cycle of increasing demand, increasing workload, and decreasing, at best stagnating, but I think it's pretty clearly decreasing supply of GP workforce. And this graph here, which comes from John Appleby at the Nuffield, just shows you the difference between hospital consultant numbers and GP numbers in the last couple of decades. And all I want you to focus on is the purple line at the top, which shows percentage change in number of consultants, i.e. going up pretty steadily, and the green line at the bottom, which is what's happened with GPs. So the number of GPs increased through the noughties, kind of flatlined to about 2014, decreased pretty significantly. There's a little gap in the data there because we changed the way that we count GPs, but has been decreasing ever since. So that's the broader context of general practice at the moment. There is, of course, further one could go into that tale of woe. I'm not going to for now, but I just want you to park that because I think it's important when we come on to thinking about what is politically possible. And I want to move on to talk about the inverse care law in general practice. Many of you will recognise this chap, Julian Tudor-Hart. He is one of my personal heroes. He was a Welsh GP. He died in 2018. He was the first doctor to routinely measure every patient's blood pressure. I think he had a system of filing cards because this was, of course, way before the computerisation of medical records. And his practice was the first in the UK to be recognised as a research practice. But as well as that, he was also the author of a seminal 1971 paper in The Lancet on the inverse care law, which he defined as the availability of good medical care varying inversely with the need for it in the population served. That's probably the definition we all learnt at medical school, but I just wanted to share this with you, mostly because I like it. He actually goes on to write, this inverse care law operates more completely where medical care is most exposed to market forces, and less so where such exposure is reduced. The market distribution of medical care, he says, is a primitive and historically outdated social form, and any return to it would further exaggerate the maldistribution of medical resources. I'm just going to leave that for you to ponder on. And what we're going to do now is spend some time looking at to what extent this inverse care law that Julian Tudor-Hart described over 50 years ago persists in England now. The data I'm going to show you all comes from Health Foundation work, which I want to be very clear is not just me, it's a bunch of extremely talented colleagues too. So the first thing we're going to unpick is need for healthcare equally distributed in England? I know you know the answer is no, but indulge me in showing you the extent to which need for healthcare varies and how that translates into demand for general practice. So what you're looking at here, just to orientate you slightly, is a graph that shows the percentage of patients with 2 or more long-term illnesses by IMD score. IMD, the Index of Multiple Deprivation, a composite of 7 measures that together reflect the aggregate deprivation, socioeconomic deprivation level of a geographical area. 1 over on the left side of your screen is the most affluent area, 10 is the most deprived. The different colours just represent different age groups. And what I want you to look at is just the pattern. which is that as we move from left to right, from richer to poorer, the number of people living with more long-term illnesses increases, and people accumulate illnesses at an earlier age. So in the most deprived areas, people can expect to have 2 or more health conditions by the time they're 61. In the most affluent areas, it's 71. And almost 1 in 3 adults in the most deprived areas have 4 or more health conditions, compared with 16% in the least deprived areas. If we translate that into specific health conditions, we look at these graphs, which show you the prevalence of chronic illnesses by age group. And I don't, the overall pattern is clear here. I really want to make one point, which concerns the black dotted line. All of the other lines just reflect the prevalence of different illnesses as you go from richer to poorer areas, richer on the left, poorer on the right. So as you would expect, almost all of these chronic conditions are more common in poorer areas. And that's the same in younger people as in older people, except for one, and that's the black dotted line. And that black dotted line reflects the prevalence of cancer. And when you first look at this, you probably think, well, that's a bit odd. Why is the prevalence of cancer lower in more deprived areas? And then if you think a little bit more, you will very quickly realize what is going on here, which is that I am showing you a graph of prevalence, not incidence. The incidence, the number of new cases of cancer, is of course higher in more deprived areas. But sadly, and reflecting back to that data I was talking about a moment ago on health inequalities, people who live in poorer areas live less long with the cancers that they have. So because we are looking at prevalence, then the number of people with a condition within a population, the prevalence of cancer is lower in more deprived areas. And that's, of course, in part associated with the type of cancers that are more prevalent in more deprived areas. They tend to be smoking-related cancers with poorer outcomes. So more health need in more deprived areas. I just want to show you this graph, which looks at consultation rates. So how frequently people are going to see their GP. So this is number of consultations per person per year on the x-axis and time, on the y-axis and time on the x-axis. And again, wibbly because it reflects a period of time in which we had COVID lockdowns. But all I want you to focus on is 2 colors, the red at the top, which represents the most deprived areas, and the blue at the bottom, which represents the most affluent ones. And what you'll see is that there's a pretty big gap in consultation rates. So in our richest areas, people consult on average 4.5 times a year. I know you can't really have a half a time, but it's an average. In our poorest areas, people consult on average 6 times a year. So pretty big gap in consultation rates. And just to illustrate in very basic terms what that means, if you're a practice in the poorest 10% of areas and you have a list size of 10,000 patients, they'll generate on average 60,000 appointments in a year. If you're a practice in the richest 10% of area with the same number of patients, 10,000, those people are going to generate around 45,000 appointments a year. That's a pretty big difference. That 15,000 appointments translates to 28.5% more appointments for the same number of patients in a deprived area. So is that a problem? Well, if the availability of general practice is proportionate to that need, then it's not a problem at all. But as we've got a little bit longer to go in this talk, you have probably surmised that I'm going to tell you that it is a problem. And I'm just going to spend a couple of slides showing you why. And this is again from work we did at the Health Foundation. So this first slide looks at payments to general practice. We'll come on to talk about payment in a little bit more detail in a couple of minutes. But for now, I just want you to look at the total payments into general practices. So this specifically is not GP take-home pay. This is how much money does each practice receive to meet its contractual requirements. And all I want you to focus on, again, is the color coding of the graph. Now, I've just shown you that there is more health need in deprived areas, so we would logically expect that GP practices in those areas get more money to meet that extra need. In this graph, green is practices in most affluent areas and red is practice in most deprived areas. So it doesn't take long to look at that graph and see that actually the inverse of that is the case, that practices in more affluent areas get more money than practices in more deprived areas. And it's almost a linear correlation. And if we put that in words, practices serving more deprived populations receive about 7% less funding than practices serving more affluent populations. What's the situation with GPs? Well, I just want you to focus on this top graph again, where the same color coding is in place. So what we see is the opposite of what we would logically expect to see, i.e., there are more GPs in more affluent areas, and it is an almost exact linear correlation. As you move from more affluent areas to more deprived areas, the number of GPs, the workforce supply per 100,000 people, decreases. So there are fewer GPs in our most deprived areas. In fact, a GP working in a practice serving the most deprived patients will be responsible for on average 10% more patients than a GP serving patients in more affluent areas. The bottom graph just shows you that the opposite is the case for nurses. There are more nurses per head in areas of high deprivation, and we don't know exactly what's driving that. We've done a bit more research in the last couple of years. We've just updated it recently, looking at what's happening with the distribution of the PCN workforce, so these additional roles that have now funded in general practice. And the answer is not straightforward. There are some of more roles in some areas and fewer in other areas. There are particularly fewer paramedics working in more deprived areas. And one last thing I wanted to point out while we're on workforce is that there are a disproportionate number of older GPs aged over 65 working in the most deprived areas, which is of course worrying, because at some point, presumably, they are going to want to retire from practice. And at the moment, we are doing very little to address this problem. This graph here, which, sorry, we published somewhere else, so we've lost the color coding, just shows you how much time patients get in an appointment and how that varies by deprivation. So what we see is that at all levels of deprivation, patients who have multiple health conditions get more time in a GP appointment. The gap in time is not big, right? Like most appointments, a theme and variation here of around 11 minutes long, and we did this by looking at CPRD data. But what you see is that in poorer areas, at all levels of multimorbidity, people get less time in a GP consultation. So the greater health needs of those people isn't reflected in longer consultation lengths, which doesn't make sense from an actually addressing their health needs perspective. But when you think back to everything I've just told you about workforce funding consultation rates, it kind of does make sense, unfortunately. And then this is not work we directly did at the foundation. This is work we funded colleagues in Manchester to do, looking at GP turnover rates. And unsurprisingly, perhaps GP turnover rates are higher in more deprived areas. Practices in the most deprived areas have turnover rates that are almost 10% higher than practices in the most affluent areas. And, clearly GP retention is an issue in many, many places, but high turnover is a concern for a range of reasons. It's destabilizing for practices. It affects your ability to provide continuity of care, which of course we know is associated with so many positive outcomes for patients. There are financial costs associated with high turnover. There's big costs in terms of staff morale, and ultimately it has a negative impact on quality of care. So, compared to more affluent areas, general practice in areas of high deprivation has greater population health need, has higher consultation rates, it gets less funding, has fewer GPs, and shorter GP consults. And I'm not going to show you the graphs for these, but I hope you'll take my word for it that GP practices in deprived areas perform worse on all three major quality indicators: the Quality and Outcomes Framework QOF, CQC inspections, and the GP patient survey. And again, those are almost linear relationships. So as you go from richer to poorer, practices perform more poorly. I should add that obviously they are slightly blunt indicators, but they are the national indicators that we have. So hopefully by now, I've convinced you that the provision of general practice in England is currently inequitable. Just as Julian Tudor-Hart described in 1971, here we are in 2023. What I want to convince you of next is that we won't successfully tackle health inequalities unless we level it up. And I'm not going to show you a bunch of graphs for this. I'm just going to try and make a very simple point around proportionate universalism, which is, of course, the resourcing and delivery of universal services at scale and intensity proportionate to the degree of need. Michael Marmot has written and spoken extensively about this. But my argument to you is that unless we resource our health system in line with need, health inequalities are likely to widen. We know that general practice can play a massive role in improving health. Evidence is particularly strong around things like prevention, secondary prevention of cardiovascular disease. But at the moment, there's effectively more general practice in richer areas, ironically, the areas where there is less health need, which also means that people who are living in more affluent areas tend to have better access and, I would suggest, treatment from general practice. So it is entirely logical that health inequalities will widen. And the challenge is that whatever interventions you put in to tackle health inequalities, and there have been some in the last 10 years, of course, not as many as there were in the 10 years preceding that, but there are some attempts. NHS England currently has its Core 20+5 strategy, for example. All of those efforts are landing in a situation where you have fundamentally inequitable provision. So they are likely to be most effective, unless they are very well targeted with additional resource, which they rarely are. They are likely to be most effective in the most affluent areas, which will in some ways be positive, because of course there are some people who experience socioeconomic deprivation living in affluent areas. But my suggestion to you is that to make meaningful progress on tackling health inequalities, we need to level up resourcing so that resources are proportionate to need. And then when we act to intervene on health inequalities, those land in the context of equitable resourcing. What I want to do finally is try and make the case to you that levelling up is possible, but it requires political will that isn't currently there. And this is the sorry story of the Cahill formula. What I'm going to do for just a couple of minutes is talk about how general practice is funded, because this is fundamental to understanding why we are where we are at the moment. And as some of you will know, general practice is funded on a weighted capitated basis. So what that means is that GPs have a registered list of patients. They get paid per patient on their list, and a weighting is added per patient, which is in theory meant to account for the workload associated with caring for that patient. The name of the formula we give to this is the Cahill formula, confusingly sometimes also called the global sum formula. And that formula is weighted on a bunch of factors: patient age and sex, there's a staff market forces factor, there's a bit of money for rurality, basically a group of factors that were intended to adjust for the workload associated with caring for a patient. There is some adjustment for perceived additional need based on standardized mortality ratios, but there is no direct measure for deprivation in the Cahill formula. So what that means is that this formula inadequately weights for the additional need associated with living in a socioeconomic deprived area, the impact of that on healthcare needs. So a fairly recent study, 2019, I think it was, by a team at the University of Leicester, looked at this, and they worked out that for each 10% increase in IMD score, practice payments to general practice increased by just 0.06%. Now, the Cahill formula, the global sum, isn't the total of income into general practice. For most practices, it accounts for about just over 50% of their income. And there are other income streams. Practices get income from QOF, usually about 10% of their total income. There's some activity-based payments. Practices get payments for specific initiatives. We often call those locally enhanced services. And then there's a bunch of other smaller payments for things like practice development, premises, and so on and so forth. But on all of the major income streams, practices in deprived areas get less money. So they get less money through Cahill, they get less money through all of the outcome and activity-based payments. And my argument to effectively anybody who will listen is that this is something that fundamentally has to change. And there have been attempts to change this for many, many years. So Cahill was brought in 2004. Prior to that, there was a system called deprivation payments for general practice. So effectively top-up payments for practices in deprived areas, calculated using something called the Jarman index. And the idea was that practices in deprived areas got a bit of top-up funding to allow them to meet the additional needs of their populations. That went in 2004 because the idea was that Cahill would cover it all, but it clearly didn't. And in 2007, a formula review group was convened by government to look for and suggest recommendations to address any shortcomings in this formula. They looked and they found shortcomings specifically around deprivation, and they specifically recommended that the formula be adjusted to include a weighting for IMD score for deprivation. That actually went to a vote of the profession in 2008, and the profession voted against it. 62% said no. So that was that. It hasn't gone to a vote of the profession since. There have been suggestions to get rid of Cahill in the GP Forward View in 2016, for example, our last kind of massive policy, national policy document. I think the formula was described as not fit for purpose. This is me chatting to the Health Select Committee about it this time last year. And somewhat gratifyingly, they did include a recommendation in their subsequent report saying that the government and NHS England must develop a better mechanism to award funding to more deprived areas to replace the Cahill formula. They described it as insufficiently weighted for deprivation and said that funding change should be used to support further work to ensure equal access to general practice across the country. Well, so far so good. And it has been great that in the last couple of years, the RCGP have felt able to support this, as have NHS England. But here is the tricky bit. When that went to a vote of the profession in 2008, there was no extra money on the table. And this is partly why I did that 30,000 foot view of general practice. What I would suggest to you is that nobody in general practice is having it easy at the moment. Everybody, practices everywhere, are completely slammed. And general practice does not, I would suggest, receive a big slice of the overall NHS pie. It receives well less than 10% of total NHS funding for delivering somewhere near to 90% of NHS contacts. So it is an extremely lean service. It is very, very difficult to suggest to GPs that some should lose money so that others can gain. I think that there is a way around that, and it's a pretty straightforward one. It's that you put money into the system so that you bring practices in deprived. You can hold funding to practices in more affluent areas, little or, I mean, I would argue funding needs to be increased full stop, but you at least hold practices in affluent areas steady. You don't take money away from them, but what you do is you introduce a better needs-based funding formula for general practice that properly accounts for the need associated with socioeconomic deprivation, brings practices in deprived areas up to and above so that you're resourcing proportionate to need. Why does that require political will? Well, because it requires money. So it is fantastic that we have the Health Select Committee saying this. It's great that NHS England have indicated their willingness to change Cahill, that RCGP are behind it too. But the fundamental challenge is that we need money from Treasury, which means that we need government to agree that this is a priority as well. And I just want to wrap up by saying that I understand that funding is not the be all and end all of this. We started out in it was 2019 when we did a lot of the number crunching, but publishing this briefing in 2020, which sent out the degree of the persistence of the inverse care law. And I then spent almost a year with colleagues looking at the range of policies that had attempted to tackle it in the past 30 years to try and work out what had happened to each of those policies, what worked and what didn't. It was abundantly clear that funding is the big one where nothing has happened. Since 2004, we introduced this formula that turned out to result in inequitable distribution. We've been unable to change it since. But there are areas where progress was made, albeit progress that has been reversed under the most recent governments that we've had. But just one example of that is on workforce. So by 2010, 2011, there were more GPs working in more deprived areas than more affluent areas. So there had been a reversal of that inverse care law, or at least where workforce was concerned. And that was the result of a bunch of policies that New Labour had implemented, including something called equitable access to primary medical care, which was effective a build it and they will come strategy. So they built over 100 shiny new health centres in the poorest local authority areas in the country, with the intention that that would attract GPs into work in those areas. And it seemed to work. I accept that it was in the much broader context of a national strategy that aimed to tackle health inequalities. But the reason that I wanted to raise that as well is because when we look back over the history of attempts to tackle the inverse care law, we can see that you can tackle it, that policies can make a difference. So I would argue that we just have to have better policies and political focus on this. So I hope by now that I've convinced you of these 3 points, that the provision of general practice is inequitable, that we won't tackle health inequalities until we level it up, but that levelling up is possible and requires political will. I'm going to stop there. I'm very grateful for all of your time, and I'm very happy to take questions.
Well, thank you very much, Becks. That was fantastic. And I have to say, I feel a slight blast from the past. I'm feeling distinctly old. When I was working in Southampton, our department was visited both by Julian Tudor Hart, who was then in his prime, and Brian Jarman, who was responsible for the Jarman Index. And both were very inspirational figures, I have to say. And I can see you're going to follow in their footsteps in many respects. So well done. So time for questions. Please put your questions in the chat. And you can read them out if you want to, but I'm going to read the first one out because Tim Jack tells me that his microphone isn't working. And his question is, thank you for a fascinating talk. Any evidence in the UK or the US regarding likely impact of more private healthcare on these health inequalities? Or perhaps I should read that as more private healthcare on these health inequalities. So over to you.
It's a very good question and one that I don't know the answer to. I was looking recently to try and work out whether more private general practice is happening in the UK, and even knowing the answer to that is exceptionally difficult. And I think the reason for that is that a lot of the time it's companies providing their own data. So it's I suspect we will be stymied in our attempts to find a true answer to that, because actually, but they exist outside of the framework of NHS data reporting, which is actually having spent a year in the States and with their complete lack of national data on anything, I have never felt more grateful for how incredible the data that we have is. But private healthcare exists outside of those data frameworks. So it's very difficult to know because they're just reporting numbers that, presumably the more people you can say you have, the better. What I would say here is that, interestingly, almost all healthcare is privatized in the US, and even non-for-profit systems are still generating profit. They are just storing it as investments. They're not charitable organizations as far as I can work out. But the government here has really incentivized private provision in very underserved areas by making a very lucrative type of insurance contract. And that is working in the sense that it is really improving provision in some underserved areas, but is also generating this very strange market effect where those organizations, if you want to Google one, a recent acquisition was called Oak Street Health, they're now being bought up by huge conglomerates, Amazon, CVS's, Walgreens, for billions and billions of dollars. So it has become quite a lucrative market catering to underserved populations, in part because of government's efforts to provide better care to them, which I think is a very interesting phenomenon and hopefully not one that we're going to have to grapple with in the NHS.
Thank you. I have to say, my limited experience of American healthcare is it doesn't set much of a role model for this country, in spite of what the politicians here so often are telling us. And this phenomenon of uninsured people, massive numbers, uninsured and uninsurable, and also the phenomenon of people who are made indigent by healthcare costs is something I really wouldn't wish on this country. But thank you for that answer. Ian has the next question, so I'll let him ask himself. Over to you, Ian.
Yeah, thanks, Peter. Thanks, Becks. Absolutely fantastic talk. Just a question, and I've sort of put in the chat bar there that I comparators to the particularly EU neighbours, where we're probably a little closer than the Americans. But how about the numbers of GPs that we have compared to our neighbours? And also, are there distortions in our local neighbours with regard to the provision versus deprivation? And are there any lessons that we can learn from them?
It's a very good question. We have tried to look at it a bit, and again have been slightly stymied because it's very difficult to compare the models, really. And it's an array, we have fewer GPs per head than some European neighbours and more than others. I don't think there is, if anyone is interested, Zeke Emanuel wrote a very good comparative book on international health policy that I learned a lot from. I don't think there's compelling evidence that I've seen to suggest that any other country has this entirely sorted, but I think that probably countries are grappling with different problems. So I, at the moment, have focused the Health Foundation's attention on trying to work out how I am not sure that I can make the argument to government more compelling by looking at examples from other countries, because I think they would suggest that it is just too different. I think, and that is obviously just talking about equity, because I think we're talking about some quite specific nuances in risk allocation formula here. I think there is, of course, an enormous amount that we can learn from other countries in their broader approaches to how to deliver primary care more effectively.
Thank you for that. The next question comes from Angela Wilson. I'm not sure whether she's able to ask the question herself. If not, I'll read it out. Angela, are you there? Okay, well, I'll read it out for her. So she says, predictable question from me. How much energy and time should doctors and other healthcare workers put into advocacy, stroke political work, stroke activism in order to try to change legislation, as that may have one of the greatest effects on health inequality?
What a great question.
And she's got a second question. How important do you think it is for all to have easy access to quality natural spaces, given the evidence of health benefits this gives? And how do we manage to achieve this? So there you are.
What great
two questions in one.
Right, to take the first one, it's a personal thing, isn't it? I think, look, I have clearly made a personal decision. I feel like I have the best jobs in the world. I get to be a GP in Blackbird Leys, which has its challenges, but is enormously fulfilling in so many ways. And I get to play a very small part in trying to slam my head against the brick wall of government sometimes in changing the wider policy around the ways that we deliver primary care. And I think that one can make a huge contribution in, people make their contribution in different ways. I guess it's how we all personally feel about it. What I would say is that I think doctors have an important voice, and that for people who choose to raise it, it is heard. I was quite surprised when I first moved into kind of health policy world, how few clinicians work within that space. So I think, for people who have that interest in working at system level, your voice is powerful within it. It's also something I'm aware of. You have to also hold that privilege and power carefully, I think. And your second question about health benefits of open spaces, look, I agree with you. I've spent the early part of my morning swimming in the bay. It brings me joy. It is clearly good for my mental health. We all enjoy open spaces in different ways and probably recognize that. I think there are interesting questions. Folk on this call may have strong views. There is an increasing movement to tackle the social determinants of health through healthcare. And something that I am interested in is thinking about where the boundaries of that should be. So, for example, we have this rollout of social prescribing link workers through primary care networks into general practice, the intention being that they connect our patients with non-clinical interventions that are aimed to improve their health. Now, intuitively, that to me makes loads of sense. If a patient doesn't have a fridge and can't keep insulin cold or whatever it is that needs to be stored cold, it makes sense that I would know about that and alter my prescribing behavior accordingly. If my patient is lonely, that's going to, we all know that these things have a massive impact on people's health. But my question is how we resource that, and whether we are adequately resourcing that. And I guess I mean that in two ways. One is that I'm really worried because the rollout of social prescribing link workers was, of course, equal across the country. It was every primary care network gets X number. It was 1 or 2 to begin with. It's now expanded. It wasn't in proportion with need. So, and I would suggest to you that there is probably more need in some areas than others, but that wasn't recognized in the policy. And this is not old policy. This is 2019. So we're still repeating these mistakes. And the second part is that there aren't, of course, equal community assets. My personal perspective is that there's been quite significant asset stripping in the last 12, 13 years, and that it places quite a burden. We're socially prescribing, but what are we prescribing to? And is it a fair burden to place on relatively unsupported voluntary and community sector organisations? And then back to that equity question, are the community assets available in proportion with need? And again, my suspicion is no. So of course, I agree with you about the importance of open spaces. And I guess I broadened it to talk about the importance of social prescribing. These things to me intuitively make sense, but I have a lot of thinking to do personally about how I think we should integrate those into an already overburdened healthcare system and how we do that equitably.
Thank you. So the next question comes from Lawrence Lever. So over to you, Lawrence.
Hi, Becks. Thanks very much for highlighting this ongoing issue. I suppose one of my worries is that if we have too much focus on health, we may not be dealing with all the social determinants that Michael Marmot and you've been talking about previously. So has there been any progress with the inverse care law in other public services, education, social services, amenities, etc., etc.? Is there anything health can learn from them, or they can learn from health, or is it all still subject to adversity, if I can call it that?
Lawrence, it's a really good and it's a difficult question. Like I think no is the bottom line. And I think this answer would have been very different had we been talking in 2010. I also want to be clear about the remit of my area of expertise, which doesn't extend to all of those. So I'm sure there are good examples of efforts to tackle health inequalities through education and other public services.
Free school meals, maybe.
Free school meals is a good example. Sure Start was probably a better example. And I suppose just reflecting back on that piece of work we did on, wider policies that have attempted to tackle the inverse care law, one of the things that we learned from that is that the wider context is vital. So that set of policies that were enacted in the early noughties were in the context of a new Labour push on health inequalities that have, as we all know, included things like early years education and, a broad programme of improvements to public services. And my feeling, Lawrence, though I can't evidence this for you, I'd be interested to know whether or not you agree or disagree, is that focus was really lost in 2010 and hasn't been replaced. And so we have not had the same kind of laser-like focus on improving public services with a health inequalities angle underneath it. And I suspect that actually matters a great deal.
Thank you, Becks. Lydia Akinola had a question. I don't know whether she wants to ask it herself or would prefer me to read it out.
I can ask it. I just wondered to what extent you thought that race or racism had impact on these on the care given and also the inequalities itself. I imagine there'll be differences. I mean, deprivation can be seen all over the country, but it can look quite different from an inner city setting. Well, I guess, as you said, context is everything.
Yeah, it's a great question. I am not an expert and I'm wary of stumbling into it. I think it's very clear that, and again, this is a very personal perspective, I would argue that we are structurally racist, as is the NHS and the institutions that we work within. And so I am sure that there are aspects of this that play out in all sorts of different ways. It's very clear from national survey data that experiences of access and overall satisfaction with general practice is worse in some minoritized ethnic groups than others. It is also clear, so we did a paper last year at the Foundation looking at how continuity of care varied by ethnic minority, and effectively you see the same kind of patterns ingrained by racist environments, which is that continuity of care is worse in minoritized ethnic groups, and that persists independent to deprivation. So people who live in deprived areas are less likely to get good continuity of care. People who are from minoritized ethnic backgrounds are less likely to get good continuity of care, and those two things are additive. I also think that, and I'm speaking very personally here, my perspective would be that because we are institutionally racist, we have not earned the right to collect a lot of the data that we would need to really understand the extent to which these problems play out, but I am certain that they are there.
Thank you. Thanks.
Thanks, Becks. Sandy Wood next. Can you unmute? Sandy is still there. You should be able to unmute now.
Yeah, I can unmute now. Sorry, I couldn't unmute before. And that was a brilliant talk. Thank you. And really interesting. We looked at some of this during COVID from a military point of view, and one of the things that we identified when we were looking to support the NHS was there was other access to healthcare that weren't just about the funding. And my question, I guess, is that who do you think should be looking into these other barriers to access to healthcare? That aren't always just completely overt. And the last question sort of got onto that with regard to some of the inherent racial bias that we find within the NHS. But there's lots of other restrictions for healthcare, and who should be doing it, given that both primary care in the socially deprived areas are both under significant pressure.
It's very difficult. I think the easy response is to say, well, government needs to look at it, and NHS England needs to look at it, and of course they do. But I think that there is a risk that things that are done nationally don't always get really down into communities, and communities are where we really need to be listening to people's experiences. I was quite struck a few years ago learning about an approach taken in Leeds called Poverty Truth Commissions, which some of you may be familiar with, but it was effectively bringing people with a lived experience into a room with policymakers, but the policymakers just were there to listen and everybody else was there to talk. I think there are obviously barriers. How do we make people after decades of not listening to people, how do we help people really genuinely feel heard and feel safe in these spaces is I think a very valid question. But my personal reflection would be that we have to find ways to really work within communities and listen to their experiences, ideally with very senior policy, with the folk who are making decisions in those rooms listening. And so that's what I guess I would mean by government and NHS England in my idealized version. But I think I saw a question in the chat quickly about how we do this and talking about the role of public health. And I think this is back to that 30,000 foot view of general practice, which is that practices in the most deprived areas are, nobody is not under pressure, but pressures are greatest in the most deprived areas. They have less headroom. And so I think we have to think about, well, where can we draw resource from outside general practice to help general practice to think about this? And part of that, I think, is the interaction with public health, which is, out in local authorities at the moment, but can we work more closely with colleagues in public health? I'm also personally interested in thinking about how we scale things in general practice so that we can be more efficient in what we do at small practice level, but how do we take workload off? How do we create headroom? And how do we do that more in deprived areas? Because we know that that's where some of the greatest problems are, though of course there is need everywhere. I want to be clear that you're not overlooking, I don't want to paint a rosy picture of general practice across the nation here. I think we also just have to acknowledge that it is worse in some areas than others.
Thank you. Well, I think you've dealt to a certain extent with Penny Toff's question, which was in the chat, but I'll just ask her to unmute and see whether she wants to enlarge on that further. Penny?
Hi. Sorry, my voice is going, and I'm afraid that I had this person keeps calling me back, so I keep missing great chunks. Do you mean the thing that I wrote originally, or in response to what was just being asked? I wasn't sure what you meant, but I'm sure
take it whichever way you like, Penny.
I'm sure you were highlighting, Becks, this huge problem about the fact of most deprived people just never making the data in the first place, and how problematic that is when it comes to trying to understand about health inequalities. So it was really just responding to what Sandy had said, as you've just said, Becks, really. But of course the problem is that a lot of the resources are just not there in local public health to be all things to all people, or even a few people anymore. This kind of thing was exactly the kind of thing that we were engaged in all the time in primary care trusts, because we were right there alongside GPs. And I did a lot of for myself, and particularly in the area of immunisation. And there's just isn't any substitute for actually going and engaging with the communities that are affected, really. And there are lots of different ways to do that. And it is really the only thing that you can do. So then maybe, and you probably did cover, and my apologies for not having been able to in the end listen to half the talk, the kind of things that could be determined at national level. There may be things that can be determined at national level by listening to people, but I think that a lot of this stuff is local when it comes to local communities, because no two local communities are the same. So it does depend what your actual population is, you know. It depends who your deprived population is, and so you have to be able to engage with them. And I just think that's absolutely beyond the capacity of GPs themselves to do. I mean, yes, you can, in the sense that if you found out from local communities that they would go and see their GPs if they were based in a different place, or if there was an outreach thing, then yes, of course, that can translate into work with GPs. But I don't think GPs are set up or have the capacity to be able to explore those public health issues in the initial stages anyway.
Yeah.
But
Tony, I agree with you, and something I would just reflect on is, you know, we go through these big NHS reorganisations on a seemingly regular basis, and the latest one is, of course, moving from CCGs to ICSs and ICBs. And something, you know, when we're thinking about, well, okay, how would this work? I think it works if you have really good locality-based commissioning, you know, people who take an interest in what is going on in communities and create ways to bring people together. I'm aware in this conversation, for example, that, you know, set in Oxford, probably Luther Street practice is dealing with the very most socioeconomically deprived, you know, our practice that caters to people who are homeless and vulnerably housed. And how often do they get to be part of the conversation? And their data is often excluded from those big national data sets. So who creates the fora where we come together to talk about this? Well, I think that is dependent on really good locality-based commissioning. And how do we create the environment for that to happen? I guess I put it to you, I'm not sure that it is by reorganising our deck chairs every few years. I think the benefits of reform are often overestimated, the difficulties underestimated. And one of my worries at the moment is that, as you'll know, primary care has relatively little representation on integrated care boards. So, you know, how do we make the case that we need really great commissioning for primary care when, in fact, primary care has a pretty small seat at the ICB table, at least legislatively it does. I think there are areas where it has been recognised that having lots of seats for primary and community care is, in fact, a good idea, but the legislation requires one seat. So I have concerns about that.
Thank you. I mean, I think, I see Penny's waving there. I'll just ask a supplementary question there. I'm going to unmute you again and call you back in. Bear with me a second.
yeah,
okay, Penny.
I agree with you, Becks, but I would say as well, obviously it's deeply biased there, but you know, public health doesn't have a seat on the ICB, you know, and you know, I don't think you should have to choose between different clinicians. Public health and ICB, everybody should be there. But if you don't, you know, if you need have public health there, then the other stuff will probably follow from that, because that's public health. Go and talk to other clinicians. That's part of what we do. So, but yeah, unfortunately, you know, we worked hard to try in the BMA to try and get that mandated, but and we had lots of lords and ladies in particular, actually, who tried to advocate for that in the House of Lords, but unfortunately, it didn't make the bill. So all of from our different corners can work on that by communicating with the local ICB. To ask them where are they going to get their public health information from directly, where are they going to get that information from? When they do have people there, they don't not have people anywhere, but they don't have them on the board itself.
Well, thanks, Penny. I mean, this is a huge area, isn't it? I can see another meeting coming up about the changing status of public health and how the government doesn't understand it. Not that implies that they understand anything else about healthcare, but we're going to be running out of time fairly soon, and I can see that Helen and Ian have questions, and I know Angela has some comments to add. So shall I call in Helen first, and you can ask your question?
Hi, Becks. Thanks for a fantastic talk. Even though I have had it before quite recently, but it's still a very, very good talk. That's my fault, not yours. I'm just so concerned about the loss of GPs. So we've got there were some figures that came out recently that showed sometime last year we lost 25% of our GPs under the age of 30. Yeah. So you'd think that those leaving the practice, the profession, are us oldies retiring early, but that's not true. It's people who've just trained, decided they can't do it. And I was just wondering how this work that you do ties in with your next gen GP work, and whether you're able to fire people up with enthusiasm for those challenges of working in the really tough areas, and what thoughts you've got about making the job doable so that next generation stays.
It's a really great question. I'm going to try and pick it off in bits. The first thing, for folk who don't know, Next Generation GP was just a program we set up quite a while ago now, 7 years or so ago, while we were fellows to Bruce. It aimed to energize, engage, and empower sort of the next generation of GPs. The idea being that, you know, we'd come off the back of the then junior doctors contract dispute in 2016, feeling quite disengaged, disempowered, or rather very engaged but very disempowered. And all of a sudden had access to these folk who understood how the NHS worked, but we weren't being taught about that in GP training, and nowhere do you learn how money works and what commissioning is and all these things that actually you kind of do need to understand if you want to be able to change the structures that govern, you know, your working and therefore rest of your life and so on and so forth. So we set up Next.
Sorry, Becks, that's been my fault as your trainer.
I don't think it was, Peter. It's the GP curriculum. And so through Next Gen, you know, we set up this tiny program. It had 60 people the first time. We set up a distributed leadership model, and almost 3,000 folk have gone through it over the last few years. It's proved enormously popular, which is no credit to us. It's led by local GPs in their areas, and it's led by early career GPs. It's intended for the first 5 years. People can realistically join at any point. For me, it has been a great source of, I've learned a huge amount through it, but also it is a great source of hope, because as you say, Helen, like, it is clear that it is not just later career GPs who are reducing the amount of time they spend in general practice. It is GPs at all stages in their careers. But through Next Gen, I at least have hope that there are people who are enormously committed to general practice. But I don't think you can say, well, because we have that, that's okay. I think it is abundantly clear to everybody that we have massive workload problems, that job satisfaction is rock bottom. We published the Commonwealth Fund survey yesterday. You know, every time we publish that, and it comes out every 3 years from the Health Foundation, we have to think of how can we come up with a title that somehow reflects the fact that this is getting worse and worse. We've already done under pressure. We've already done feeling the strain. What can we do this time? You know, it is clear that these problems are just escalating, and it's a really difficult, you know, it leads us to some really difficult questions about how we break the vicious cycle of workload in general practice. Colleagues at the BMA, I think you'll have seen, are having discussions about, well, what is safe working? What are safe working hours? And clearly none of us work anywhere near our contracted hours. And how do we think about this in a way that delivers care that is safe? Now, clearly government has some ideas in terms of expanding the workforce to take some pressure off. But actually, I think two things are true. One is that was a massive skills mix change in general practice with very little transformation support. So almost certainly those staff members aren't as well supported or integrated as they could have been. And that is probably meaning that scheme is less effective than it otherwise would be. Manchester team published a very recent interesting study showing that the expanded skills mix in general practice isn't improving patient satisfaction. It's not reducing emergency hospital admissions, et cetera, et cetera. So I don't have any silver bullet or wise ideas. I have hope, because I know that I am part of a big group of fairly early career GPs who are very committed to this model of delivering general practice. And I guess that's a final point I would make. I've been thinking a lot recently about Barbara Starfield's 1994 paper on high performing primary care, and actually how the model that we have in the UK our NHS model of delivering general practice has really high fidelity to those core components of general practice, that it is continuous, that it is comprehensive, that we have a gatekeeper model, and that we are well coordinated within general practice. There are things we can improve on, but our model is good. And I think it puts it back into the political arena to think about how we deal with some of the workforce challenges. Have I answered your question, Helen, in any way, shape or form?
Yeah, sort of.
Thanks.
So thank you for that. Ian.
Yeah, thanks, Peter. It was just to note, and Becks may not have heard this across the pond, as it were, but just that locally, we now don't have just an ICB. We have an ICB collaborative, which is Bob, Frimley, and also Surrey and Heartland's ICBs are now amalgamating and seem to be moving towards operating as one. So that's interesting because it creates an amorphous beast that crosses strange boundaries and will have an enormous skew of areas of deprivation and great wealth and so on. Probably no public health input, sadly. I don't know if anyone knows, can they help us? But it also prevents challenges for anyone trying to represent, because it crosses all of the traditional regions, the old Strategic Health Authority regions, which are what the BMA organisations broadly are still organised along, and everything else pretty much is still broadly organised along. So it's going to present even more and different challenges, I think. That.
Thank you, Ian. I think it just reminds us how bizarre boundaries are, and when they keep changing. Not only does the BMA have different boundaries, but of course the Royal College of GPs has different sort of boundaries again, and political boundaries are flexible, and as we know, next year constituencies will be redrawn, so the link between MPs and their areas will be once again weakened or altered. Did you have any comments about that, Becks?
I think just perhaps I realise we're ending to end on a slightly positive note about ICSs. If anyone is interested in this, Leicester and Rutland effectively ripped up Carhill and introduced their own needs-based funding formula for general practice. They put some money in to do it. They did effectively a mini localised version of what I was articulating in my talk. They put some money in. I don't know quite which budget they found it from, but they decided this was a local priority. They mapped out the degree of their disparity between their inner city, very deprived practices, more affluent practices elsewhere in their patch. It was pretty significant. They got rid of Carhill. They used a needs-based funding formula, which they actually imported, ironically, from Johns Hopkins over in the US. So they have leveled up general practice financially in Leicester and Rutland. They're now looking at the outcomes. It cost them relatively little money. I'm going to get it slightly wrong, but from memory, it was well less than 1% of their total system spend. It was in the low millions, so not a lot of money, which tallies with what our expectations would be for general practice broadly. And they gave that money to general practices. They didn't attach lots of strings to it. They just leveled up funding. I, of course, would argue to you that needs to be done nationally. It's not good enough that we rely on pioneering integrated care systems to work it out for themselves. But I think it is an example of what ICS is. And I know Claire Fuller, who leads Surrey and Heartlands, has looked at that work in LLR. So I would love that to happen locally through the collaboration between Bob and other ICSs. I would love it to happen more because it's a national priority, because it is in a manifesto at an election for perhaps a new government. But there is, ICSs thinking about things in progressive ways can clearly make a big difference, and LLR have done it, and I was really impressed by their work.
Thank you for that. We're getting towards the end, but I'm aware that Angela had a supplementary question, which you might be able to answer before we finish. So perhaps Angela feels it's been addressed already. I will open up to her and see what she has to say.
Yeah, hi. Sorry, I think you did ask a question on my behalf. I had to leave and deal with a very noisy dog. Sorry. What was the question that might not have been asked, Peter? Sorry. I came in and heard the comment about advocacy and green spaces, but I think they might be my two questions.
Well, I think the question was to do with whether there would be adequate resourcing to deal with these issues. That was the supplementary that we got in just now. I don't know whether you feel you've heard the answer to that or whether Becks got any to add to that.
I would love to hear. How do we get the money, apart from a change of government, we said, or is that going to work or not?
Personal view here, I think if anybody would like to write to Rachel Reeves and make the case for increasing NHS spend, I would be very grateful. I think a concern that I have is that an incoming Labour government, you probably know these numbers already, average increase in spend on the NHS over the past 20 years, 4.4% annually, average increase under the Labour government, 6.6% annually, average increase under the government since 2010, 0.4% annually. So my personal perspective is that clearly more money doesn't solve all problems, but more money is needed. So I would change both the total pie and I would change the division of the pie. My concern is that an incoming Labour government might not be willing to increase spend. I'm no economist. I realise that there are different arguments to be made about what Treasury can and cannot afford, but I am worried that there may not be more money coming down the line for NHS, and I would add social care because that's probably more important in some ways. So yes, if anybody fancies writing to Rachel Reeves, trying to influence their local candidates, my concern is that we will not get the extra money that we need because any new government will stick to the existing kind of dogma around fiscal constraint for health and social care. Interesting. One final point, Health Foundation polling shows that the public is willing to pay more for it.
Those are interesting points, Becks. And I think many of us in this room, although the BMA, of course, is not a party politically engaged organisation, we are neutral in that respect. But nonetheless, I'm sure many people here feel that the time is ripe for political change. Nonetheless, perhaps since you've been in America, Labour have been making some other disquieting noises, in particular in regard to the position taken by the BMA and direct access to consultants, which I believe has now become part of their policy. And I'd be interested in your views about that.
So you mean the idea of kind of increasing self-referral?
Yep.
My understanding is that Labour plan to consult on the future of general practice. I think that they will probably, I don't know this at all. My sense is that they will row back on, I think the evidence for the gatekeeper model of general practice is so strong that it would be very difficult to kind of row back against it. I think and hope that what they will end up doing is looking for a very limited number of examples where you could feasibly, sensibly introduce self-referral. My understanding is that they will be consulting on what those will be. But I personally would strongly resist any attempt to remove the tight gatekeeping function of general practice. And I hope that will be end up being what they kind of settle on too.
Well, thank you. Thank you for that. And I'm aware time has caught up with us, and I'm sure we could talk quite a lot longer. Obviously, you've given us all a great deal to ponder on. I will hand over now to Ian, if I may. And thanks, Becks.
Thanks very much. Thank you, Becks. That was absolutely tremendous. I have to say that you made a very compelling, extremely clear explanation of the issues with very clear conclusions as well. So what have I learned? Well, definitely there is inequitable provision of GP care. Health inequalities are not going to be addressed unless we level up. Leveling up is possible. And in fact, I was interested that you showed that we have done it before. And that was a very interesting example. But it's going to require political will, which, as we've just alluded to, is ultimately in the hands of the people and the will of the people. And it's going to need new money and, I think, ring-fence money that's directed to address this issue. So thank you for all of that. it just remains for me to thank you personally, Becks, for an absolutely fantastic talk. I'm sure there'll be more discussion about this going into the future, and it'll be good to remain in contact and hopefully welcome you back when you hopefully do come back to Oxford. You hopefully won't need your bear spray kit when you do get back to Oxford.
Ian, thank you so much. I will be back, and just to say thank you so much for having me.
Thank you.
We can all unmute if we like, and we can applaud.
Yeah. Thanks very much, Becks. Just a final thank you to everyone for coming this evening. Really great to have you all here. If we get a chance to have something face to face over the next 12 months or at the next meeting, we will do. We usually have a nice dinner this evening. It'd be nice to get back to doing dinners, and really just to thank particularly the whole executive for helping to organise things, but really Peter Burke, who has done another heroic job of organising everything, setting up the IT, making it work, hosting everything. So thank you particularly to Becks, but also to Peter. Thank you. So I think we can draw the meeting to a close now, but please do email in any other issues and so on. And a final thank you to Jean for all her amazing years of service, and good luck to Sandy, who's going to take over that treasurer role. Good night, everyone.
Good night.
Good night. Thank you. Thanks very much.
Thank you so much.
Thank you.